It's my extreme privilege to begin what will be a yearly event. This will be the inaugural Farouck Obeid Memorial Lecture, generously supported by many of you in the department, by the Obeid family as well. I acknowledge all of you in attendance today. Thank you very much for being a part of what is part of the Department of Surgery family. We are going to first start off with a short overview of Dr. Obeid by Dr. Horst, and then Pat Patton will introduce our speaker, Frank Lewis. Maddie.
Well, I told Dr. Dolchewski that I had some 25 pages to read in my short introduction, and he threw the water bottle at me. So I'm very honored to say a few words about my friend, Farouck Obeid. Many of you do not know him. Others of you, he touched your lives. Dr. Obeid completed his surgical residency and vascular surgery fellowship at Henry Ford Hospital. When he started as an intern, the cafeteria was in the F basement, the ER was in a building off the M building, and the ICU was on A4. The hospital computer, was in the simulation lab. After he completed his surgical residency, he joined the staff of Henry Ford Hospital and became a very talented surgeon with a nationally recognized career in trauma surgery. And subsequently, he completed his career at Hurley Hospital, where he also had a recognized career in bariatric surgery. Dr. Obeid loved surgery, and for more than 30 years, he enthusiastically and loudly taught hundreds of students, residents, and young surgeons. He willingly shared his vast experience. Not only did he share his surgical expertise, he shared his life's experiences and political views. Dr. Obeid loved to argue politics. At the same time, he would be heaping food on your plate, saying, "Please eat more, please eat more." Farouck loved people, and it came across to his patients, friends, and colleagues. He made everyone feel that they were part of his family. Not only did he love surgery and people, he also loved his family a great deal. And we are extremely grateful to the Abid family, Gloria, Nadia, Nabil, Layla, and Nick, for making this lectureship possible to honor Dr. Obeid as a master surgeon, enthusiastic educator, and great human being.
And it is my great pleasure to introduce to you today the inaugural Farouck and Obeid Memorial Lecturer, Dr. Frank R. Lewis. Dr. Lewis and Dr. Obeid were my mentors as a young surgeon. Dr. Obeid taught me how to be a surgeon, and Dr. Lewis taught me what it meant to be a surgeon. Dr. Lewis has had a storied and illustrious career. His surgical career started at San Francisco General Hospital back in the heyday of that institution when giants walked the earth, as he practiced with Bill Blaisdell and Don Trunke and developed trauma care as we know it in the United States. Frank was, after being chief of surgery at San Francisco General, Frank was wooed here in the early 1990s to become chair of our department, where I was a junior resident, and Farouck Obeid had just taken over the Division of Trauma Surgery. Under Frank's guidance, the reputation and stature of the trauma division at Henry Ford Hospital grew under Dr. Obeid's leadership. For those of you who may not know, Dr. Lewis, throughout that time, was, as I mentioned, a giant in surgery. He's been president of the AAST, the Shock Society, the ACS Committee on Trauma, the ACS Board of Governors. chairman of the Residency Review Committee for Surgery, chair of the American Board of Surgery, and now finally executive director of the American Board of Surgery. Frank is truly a giant, and we are honored to have him return to Henry Ford Hospital today as the inaugural Farouck Obeid Memorial Lecture. And I would like to echo Maddie and Scott's thoughts and let the department know that we are honored to have our initial educational grand rounds of every year moving forward named after Dr. Obeid. I can think of no greater honor because he truly cared about the education of young surgeons, and he devoted his life, I think, to that. And so I think it's fitting that we honor him each and every year with an educational experience that we can all remember. So without further ado, Frank.
Thank you very much, Pat. It's really a great honor to be asked to give the first Obeid lecture and to be invited back. Farouck had shortly before I came in 1992 taken over the trauma division, and he continued as head of the trauma division during my tenure here. And in the latter part of that, he moved to Hurley Hospital in Flint to really establish trauma service there and to ultimately have that accredited as a level 1 trauma center, and independently developed bariatric surgery there as well. Farouck was a master surgeon and certainly one of the warmest human beings I've ever known. He was an ideal faculty member in every way. He was loyal and dedicated to the residents, stood for extraordinarily high quality surgery, and excellent relationships with his patients at all times. So it's a real honor to be speaking in his name, and also an honor really to see so many family members that are back, and Nadia, who is progressing in the family's footsteps. I think it's appropriate. What I want to talk about today is basically a giant experiment that the board is doing in education, and I think it's quite appropriate that this be the subject of the first Obeid lecture since he cared so much about resident education. I'm going to begin by talking about some of the problems of perceived surgical resident education, and then outline to you what the project amounts to that we are engaged in, so that you understand it and hopefully will be participating in it. First, I want to recap some data that we've accumulated at the board. We monitor this in an ongoing way, but I want to show you some of the most recent data. This particular graph is a summation, basically, of the performance of all surgical residencies across the country on the American Board of Surgery written and oral examinations. The horizontal axis is the qualifying examination, the written examination pass rate. The vertical axis is the oral examination pass rate, indicate the threshold levels that the RRC for surgery has established as the minimum acceptable levels for residency program performance. If you fall below those in either of the examinations, you risk being put on probation and having fairly focused visits at frequent intervals. Each dot on the graph represents one residency program in the country, and the data is a 5-year average of the pass rates of all the graduates of that particular program. You can see, obviously, that the programs are clustered here in the right upper corner. This single dot here at 100 actually represents 7 programs in the country that have a perfect record over 5 years. Interestingly, there are a lot of programs that reach 100% on one examination, in this case on the CE and over here on the QE, and yet have relatively poor performance on the other examination. And it's fairly interesting, I think, and we don't really know why. There are relatively few that are below in both. So it indicates that programs generally have problems either in getting graduates to pass the written exam or the oral exam, but uncommonly both. Only 5 programs out of 246, 248 in the country. On the other hand, if you look globally at this, the board examinations are not intended to be a high hurdle. They are intended to address basic levels of competence and performance and they are put together by faculty members exactly the same as the faculty members in this program, who are quite familiar with resident education on a day-to-day basis and who are in touch with the reality of teaching and programs, and who put together the questions that are asked in a way that they think is appropriate for a graduate of a surgical residency to know. So we're not trying to define an elite level of performance. We're trying to define a competent level of performance. Given that, it really is disturbing to find that 18 of 248 programs, or about 7%, fall below the 65% threshold on the written, and about 8% fall below that on the orals, relatively few are both, so the total is somewhere around 15% of all residency programs fall below these minimal thresholds. And arguably, it should not be too hard to get 2/3 of your graduates past the exam on the first try. So overall then, this graph represents, for all of these points down in here, they represent a substantial number of residency programs that are really not doing a great job in educating their residents. This is the obverse graph. This is a very long-term graph of the performance of individuals who take the QE and CE. The lower graph here is the oral exam, the upper graph is the written exam, and this is starting about 1975 and continuing up to 2003. And you see there's been a slow decline in this. A good bit of the high fail rate in these years was due to a very large number of international graduates who came into the country at that time, and there were a very large number of people. Normally we have about 1,000 surgical residents who finish residency in this country each year. Back in these years, there were 1,500 to 2,000 surgical residents taking the exam. The additional 500 to 1,000 were actually coming in from international programs. Many of them were poorly prepared. That's why the very high fail rate occurred in these years. But as you can see, this rate has been generally going down, but as already shown, relatively few people fail both exams. People have trouble with one or the other. And so the total number of people who fail either the written or the oral is shown by this line. And as you can see, it's about 1/3 of the people who initially apply for the program. Now, arguably, that's a very high number for a set of examinations which are not intended to be elitist, and for someone who has spent 5 years in doing this. And so the overall level of preparation of residents in residency programs appears to be significantly lacking. But this graph comes up to the present time, including the most recent examination. And I show you this because this is data that's actually quite recent. We only have put this together about 2 weeks ago. This represents the oral examination fail rate up to the present time. And I'm sure you all know what happened here in 2003 when resident work hours went into effect. And so we have seen a 50% increase in the fail rate in the oral examination since that event. The oral examination is designed to test clinical understanding, logical ability to manage cases, clinical reasoning skills, etc. And so there has been a significant degradation in resident performance over those years. There obviously are other factors that possibly would influence that, but in general, not much has changed about residencies otherwise. So we're very concerned about this trend, which seems pretty significant and clearly at variance with the long-term trend. This is the same graph for the written examination, and you don't see the same level of increase. There was an increase this year of 3 percentage points in the failure rate of the written examination, but overall, over the last several years, that would be flat. The lower graph are the first-time takers, the upper graph are all takers, representing retakers as well as first-time takers. So again, trends are continuing, which indicate that resident performance is really not optimal. The only factor we've ever been able to directly attach to residency programs which influences the outcome of these examinations is the size of the residency. And that's what this graph shows. These bars represent residencies which graduate 2 residents per year, 3, 4, 5, 6, and 7 or more. And so you go from the smallest to the largest residencies. And these bars, the height of the bar is the obverse of the fail rate. This is the pass rate, 5-year average. In this case, the written examination. And you can see there's a very significant trend of that. So the smallest programs down here with an average fail rate of about 79%, the highest at about 89%. There's about a 10% difference between the biggest and the smallest programs. It's a very significant sort of result. If we look at the combined index of the ability to get past both the written and the oral the first time, you see exactly the same trends in that. So there is clearly an effect of program size on ability to pass the exams, and presumably that's a reflection of resource availability. The smallest programs have many fewer faculty, but probably more significantly, they have much less breadth of surgery, often a smaller volume of surgery, and as a result, probably have a much more difficult time educating residents. But clearly, the problems in the smaller residencies are more significant than in the larger residencies, which is one of the problems we address. And lastly, something probably many of you would be interested in, people often ask us about the correlation between the ABSITE exam, the in-training exam, and the written qualifying exam. This is the correlation of that for the first 2 years in which the split-level examinations, the junior-senior ABSITEs were given. This is the correlation between the senior-level exam for graduating residents only, the PGY-5 residents, and their subsequent performance on the written qualifying exam. This is the percentile score on the ABSITE, and this is the pass rate on the QE. And you can see there's a pretty tight correlation there. It's non-linear, but there's clearly a relationship. And the relationship is that if you have a below a 10th percentile ABSITE percentile, your chance of passing the QE is only about 50%. If you're at the 50th percentile on the ABSITE, your chance of passing the QE is about 90%. And so from going from the 10th to the 50th percentile is obviously a huge improvement in your likelihood of passing the QE. If you're at the 30th percentile, you're somewhere around the 82nd or so pass rate. So there's very tight correlation, again indicating that performance levels of residents, and remember the ABSITE by definition has half of the people on each side of the 50th percentile, and so half of the residents are down in this region, half of them are up in here, indicating again that there are significant performance problems that are evident across the body of residents. All of these problems are not new. They've been identified for a long time. They came to the attention, I think, of a lot of people in surgery in the early part of this century, largely precipitated by bad matches, bad intern matches in 2001, 2002. In 2001, 2002, there were as many as 68 of roughly 1,200 internship positions that went unfilled, and it was the first time that had ever happened. Subsequently, that has all changed, and from 2003 to the present time, the statistics have gone back to their traditional norms of having virtually all positions filled. But there were 2 years when clearly surgical residencies were not being chosen by American graduates in the same numbers they always had. It precipitated a lot of soul searching, and among other organizations, the American Surgical, under the presidency of Haile DeBass, elected to take it on. And the issues that were identified were the highly variable performance among residency programs and an excessive fail rate among graduating residents. Much of this was thought to be due to the lack of a clear definition of the boundaries of general surgery. General surgery over the years has been many things to many people. It began back in the 30s, encompassing what is today orthopedics, urology, ENT, and many other things, and over the years it's been progressively narrowed down in its scope. There has not been any effort along the way to define exactly what general surgery is today. And the board is the logical agency to do that, because we basically make up the exams and therefore determine what you have to know in order to be certified. So the board, not in isolation, but primarily is the agency which needs to define what the boundaries are. And it's thought that if that were done better, then the ability to teach residents what they need to know would be clearer for programs and program directors. One issue that's obviously universal is that general surgical cases are progressively cannibalized to some extent by specialty fellowships which develop, and one of the problems is that specialty fellowships in most of the subspecialties of surgery do not require any form of approval. Fellowships in vascular surgery, pediatric surgery, and in the other specialties, plastic surgery, thoracic surgery, are all subject to RRC review. But fellowships in trauma, oncology, transplantation, and especially GI and minimally invasive, all of those fellowships are only approved, if at all, by specialty societies, not by any residency review committee, not by the ACGME. As a result, the standards of those fellowships are quite variable and not subject to any scrutiny, nor is the boundary between what fellows do in operations and what surgical residents are expected to do well defined. That has resulted in a significant encroachment on general surgical chief resident territory because of the development of fellowships. And that's an ongoing problem which no one has solved yet. And obviously, I've already mentioned the poor match in 2001 and 2, which precipitated a lot of thinking about this. This gave rise to something that was called the Blue Ribbon Panel, constituted by Haile DeBass. It was done under the leadership of the American Surgical, and representatives from these 4 groups were assembled and spent a couple of years in multiple meetings, ultimately issued a report which was published in the Annals of Surgery in early 2005. And it was a summary of the views of the Blue Ribbon Panel about surgical education, both in medical school and in residency. There were numerous recommendations that came from the Blue Ribbon Panel, but among others was that there was an urgent need to develop a standardized national curriculum in general surgery that would define the limits of, or the boundaries of, what general surgical is today, and also established much clearer guidelines for what needed to be taught and what residents should be expected to know. And that basically is the charge that subsequently led to what I'm going to describe for you, which is the development of SCORE. The American Board of Surgery, looking at this problem, felt that there were no other agencies that had the ability to move forward in addressing this issue, and so back in 2004 and 5, we elected to take this on. And basically, the Resident Education Committee of the board, which is one of the standing committees within the ABS, and has primary responsibility for evaluating residency, teaching, and program conditions, felt that there were 6 organizations that primarily were involved in surgical education: the American Surgical, the college, the Residency Review Committee, the board, program directors, and the Association of Surgical Educators. Those are the 6 organizations that arguably have stake in the pie of surgical resident education. So we assembled representatives from all of those groups and were able to attract Dick Bell, who was chairman of surgery at Northwestern at the time, to leave that position, come full-time with the board and direct this effort. And we created an organization called SCORE, which stands for the Surgical Council on Resident Education. So SCORE is a group of people from these organizations, and we've subsequently added a 7th organization, SAGES, to that because of their contributions in educational material. And SCORE has been meeting now 2 or 3 times a year since 2005, developing the program that I'm going to show you the beginnings of today. And basically the intent is to take the recommendations from the Blue Ribbon Panel and try to implement those in an ongoing way in order to hopefully improve resident education. The charge to the committee was shown here, to basically look at methods by which surgical training could be made more efficient and uniform, to develop a set of competencies that would define the base of knowledge. The broad view is that, and it's a long way away, but the broad view is that residency education should be based on the demonstration of competency or competency-based advancement as opposed to time-based advancement. And that while the logistics of doing that would be extraordinarily difficult, the concept is that people progress at very different rates, and if you could have a more individualized way of people demonstrating competence, it would be a big step forward in doing so. So I don't know if we'll ever get there or not, but that's an ideal that underlies much of the thinking with this. To propose methods for the implementation of competence-based training and to explore newer methods of instruction, particularly virtual reality and simulation that might be used to get there. The educators tell us that the development of a curriculum for improving education has 4 essential parts to it. The first is to identify what it is you want someone to know. The second is to develop the means by which you're going to teach them that material. The third is to have some method for assessment of what they have learned at periodic intervals in order to demonstrate that they've mastered the knowledge. And then the fourth is to look back at the whole process, see what you're doing well or poorly, and cycle back and start over again. And that should underlie the development of any curriculum. And so SCORE basically began with this first box here, beginning in 2005. And they took the approach that the way to develop a curriculum was, in essence, to say that a graduate of a surgical residency should be able to competently care for patients with a particular disease or condition, and you can substitute obviously a lot of different things for that, and that a graduate of these programs should be able to competently perform a certain list of operations. And that these should be the 2 driving principles by which the programs would be organized. And so the underlying basis of the SCORE curriculum at this point is that it is organized by diseases and by operations. And there are a series of modules, each of which addresses in a reasonably focused manner one or the other of those 2 things. We started with a list of 320 operations, which is the entire list that the RRC for surgery uses. All of the operations, there are about 7,000 CPT codes. The RRC collapses those into 320 operative categories, which is how they tabulate their results. So any of you who have looked at an RRC report, there are 320 categories that all of these operations are subdivided into, and they are further collapsed into 28 broad organ system categories. So we elected to use that structure in organizing SCORE. We didn't want to reinvent a new structure and confuse things, and that is a comprehensive approach to it. So we started with 320 operations and about 1,000 disease processes that are nominally part of the surgical process. Dr. Bell then went through, for about a year, a process of developing expert consensus among people who were heavily involved in education. He used all of the program directors in surgery as well as all the directors of the board on multiple occasions, in essence, to look at this in order to determine what should be in or out of the curriculum. And in regard to operations, he asked all the people who responded to grade the operations on that list by 3 criteria. One was the A operations were those that a resident should be competent to perform independently on completing a 5-year residency. The B procedures were those that residents should be familiar with and have an understanding of and be able to have some level of operative management, but not necessarily be independently competent to perform. And the C procedures were those that you should forget about, that should not be included in the curriculum because they generally were the purview of other specialty areas or were too rare to be normally included. This is a typical kind of ballot that he got back. This looks, for example, at a series of these operations. Cholecystectomy with or without operative cholangiograms, laparoscopic. Well, as you might suspect, most people thought it should be an A operation and very few a B or C. Looking at cholecystostomy, the opinion was more mixed. As you go down here to common bile duct exploration laparoscopically, more people thought it was a B than an A, and so forth. So there's no unanimity of opinion, but overall, by doing this multiple times, he arrived at a definition of procedures and ended up with 122 procedures, which were defined as A's, 171 as B's, and 8 as C's. And that forms the basis of the curriculum that we're going to be undertaking. Now, unfortunately, if you take those 122 procedures and you ask how often they're actually done by residents, this is data from the 2005 graduating cohort of surgical residents, the answer is not nearly often enough. And these are ranged from 1 to 122 over here. The vertical bars show how frequently they're done. So number 1, as you might suspect, is cholecystectomy, and the average is somewhere above 80 to do those, but these numbers fall very rapidly. So by the time you get to procedure number 20, you fall below an N of 10. By the time you get to number 60, you fall below an N of 2. And by the time you get out here in the last 20 or 30, you're down to 0 for the most part. So the reality is, and remember now, these are only the 122 procedures which are in the A group, which residents are thought to need to be competent in. So we have a big problem, obviously, that there just is not enough volume of procedures that people are doing to meet this definition. And therefore, we have to look intensively at the potential for other means of teaching over time. But it highlights the problem we have, and it highlights some of the reasons why we're looking at high fail rates and problems that we have already talked about. SCORE subsequently adopted 2 definitions to try and deal with this. They subdivided the diseases or conditions into 2 categories, broad and focused. The broad categories are those encompassing the most common of those procedures in that list I already showed you. The focused are those where the frequency with which they occur is far less. Broad categories are those for which residents are felt to be competent. They should be competent in knowing how to do this. The focus groups are those where their familiarity should be more limited, and they should not necessarily be expected to provide comprehensive management for all of this. Among operations, there were 3 levels of categories: the essential common, the essential uncommon, and the complex. The essential common basically corresponds to the first 65 of the procedures in the A list. The essential uncommon, the second 60 or so in the A list, and the complex, the B list. And so of these procedures, they reflect the frequency with which residents are doing them and the level of knowledge which is expected. And the intent of this is to try to develop a more realistic approach to what residents should be expected or not be expected to know about procedures. Now, the total number of procedures, if you add up all of the operations and all of the procedures in the A and B list, comes to something like 720. And trying to develop resource material for that's a massive undertaking. So we have begun, and the initial effort that I'm going to show you this morning encompasses only the operations in the essential common group. So it's the first 65 of those, and only the diagnoses in the broad categories. Putting those 2 together gives us 266 modules, and that's the starting point that we have in the SCORE website that we have developed. These 266 modules, and in fact actually the entire curriculum, is subdivided into these 28 categories. And again, this is not new. These are the categories used by the RRC. It's been in place for 2 or 3 decades, and it's just a broad anatomic definition, and it is one we will continue to use. And within each of those categories, we have developed a module based again on that heading. One of the headings in the list I just showed you is alimentary tract anorectal. And so showing you how it would be broken down into broad and focused diseases. Under the broad category, you have hemorrhoids, anal fissure, abscess, cancer, rectal cancer. In the focus group, you have pelvic floor dysfunction, incontinence, sexually transmitted infections, rectal prolapse, giving you a feel for the way in which these have been subdivided. If you do the same thing for the operations in that same alimentary tract anal rectal category, the essential common would be banding for hemorrhoids, hemorrhoidectomy, etc. You can read the list. The uncommon would be excision of anal cancer, and the complex would be the things listed here that would be more likely taught at a colorectal fellowship than in a general surgical residency. So basically then what we have put together are modules that address the essential common and the broad diagnoses. This is a brochure which is published outlining the curriculum, and so all of the information across those 28 modules and what's included in all of the categories is outlined in this brochure. And we'll have, subsequent to today, we'll pass that out to all the residents so that you can see what's involved. The topics are generally organized by those organ system categories, and you can see one such example here. They also are organized by the obverse categorization system, procedures by level. And so this system has been put up and is now organized and working, and we finally have gone down one further level so that in addition to defining the level at which the board considers this to exist, we define a series of teaching objectives within each of those modules that are thought to be the most essential teaching points for it. And so each of the 266 modules will have typically 8, 10, or 12 learning objectives which focus on what the essential points are within that area that are thought to be important. The point of this slide is to say that using the ABMS and ACGME categories, the 6 competencies, the competent surgeon can be defined in those 6 dimensions. One of the 6 dimensions is patient care, and basically what I'm showing you today in terms of these modules relates entirely to patient care. It does not include anything relative to communication skills. It doesn't include any basic science issues. That's coming along in the next 6 months. It doesn't include anything about systems-based practice or practice-based learning or professionalism. We anticipate in the future that might be done as well. So the general schema, and I don't know if we'll ever complete this or not, is to say that these are the steps in developing a curriculum that are defined by the educators. These are the competencies defined by the ACGME, and you'll note technical skill is a new one here. There's currently a debate going on in the ACGME as to whether technical skill is going to be included as a 7th competency or subsumed under patient care, and that's not been decided yet. But one way or the other, technical skill is going to enter the lexicon here as one of the skills. So theoretically, you could look at filling each of these boxes in terms of what's necessary to fully define a curriculum and back it up with learning materials. In essence, we're only in the first box here, in which we're taking patient care and identifying basic competencies that we think are appropriate and important. So in summary, in terms of where we are at present, we feel there's a need to better define general surgery and improve resident education. SCORE is a voluntary consortium of the 7 organizations that have a mission to develop a competency-based curriculum for training, and we have started basically doing what I said at the outset is an experiment to see if developing a website and defining this curriculum is going to be a useful exercise or not. And I don't know what the answer to that is. We are putting a lot of effort into this. We think that it will be useful. We think it will be something that residents can use because given the state of technology today, all of these things are things that can be used at the point of service so that you can use them in essence on your daily functioning within the hospital, can look up information in a way that will be quite easy to do. And we anticipate that this is going to be adaptable and changing with time. We don't look upon this as a static sort of thing, but it's something that will be ongoing. This is the SCORE website, and all of you, I don't know if you've signed up for this yet or not, but This will be available to all of you immediately as soon as your program director fills out the initial enrollment material and we have the log of all of that assigned. So each resident will have their own logon ID and password and can sign onto this and will have a unique page of their own. The assignments will be assignments that the program director can make to individual residents. They will then show up on the individual residents' home pages within SCORE so that they know what assignments they've been designated and what they will be expected to do. Later this fall, we're going to add ABSITE questions to this so that you'll be able to do self-assessments. Program director can basically do self-assessments based on the modular subjects at whatever intervals you choose to do that. We envision that there will be an administrative side to this, news and announcements, that will incorporate many of the sorts of things that you have in your system here that Dr. Rubenfeld was showing me yesterday in terms of administrative management of residency issues. The SCORE website will include basic issues about news and announcements, either relative to the board or to the local program. That can be filled out by the program director. The 7 organizations' logos are listed here. The publishers who have agreed to cooperate with us and license material for SCORE are shown below. Elsevier declined to be involved, so we don't have all of the textbooks, but we do have ACS Surgery, Greenfield, and Schwartz. The organization of the website is up here in these 2 areas, and if you click on the View All category, that brings up the classification of the modules, which corresponds to what I already showed you. The large title here corresponds to one of the 28 categories, and you can see you can scroll down through that and look at all of those categories, and they're an exact replica. Within those, the modules which are defined within each category are those that correspond to the broad diagnoses and the essential common operations. So if we were to look, for example, at hemorrhoids here, if you click on that, it brings up a page related to that particular module, and it includes a series of learning objectives, resources, learning activities. It relates to the contributors to that, and a series of related topics. If we look at the learning objectives, these are, as I said already, the 8 or 10 things which an editor feels are most important within this subject area. So if we take this, number 1 is pertinent anatomy and physiology. There are a series of 3 resources here. If you click on either of those, it will take you directly to the page in the textbook related to that, and you can read about that as you wish. If you want to go back and do that with another textbook, you can do so and see a different section on the discussion of the same subject area. So you can basically go into any of these standard textbooks and read about these as you wish to do. Currently, the majority of the information which is on the website is textbook information. However, we do have about 45, I believe, open operations for which there are videos, and we have upwards of 80 operations laparoscopically that SAGES has contributed, so that a majority of the operations that are on here have videos indicating how the procedure is done. A little later in the fall, we're going to have an exhaustive encyclopedia, really, of radiologic images, which will back up each of the diagnostic modules, so that if you are looking up a subject and you want to see what a classical image of that looks like by whatever CT, contrast study, etc., you'll be able to pull up multiple examples of that and see what the essential features are. If we go back here, we can pull up a video, for example, of what a ventral hernia repair would look like. And
this patient has a symptomatic umbilical hernia, and today the surgeon is performing a mesh repair of the hernia. The repair will be done under local anesthesia with IV sedation. This type of hernia has a moderately high risk of recurrence, particularly in these patients. Our incision will be below the navel in the infraumbilical fold. Initially, the surgeon raises the skin wheel.
okay, we don't need to continue with all that. I'm sure you all can watch that. But basically, you can go through the whole procedure and see that. So if you want to see how it's done for the first time, you will have a resource for doing that and learn at least one way to do it. The procedures, the open procedures, which are outlined by Dr. Bell, are broken into multiple segments, and you can look at only one segment within that if you like. The procedures which have been contributed by SAGES have already been pretty heavily edited and are typically down to 5 or 8 minute segments of specific things, so they're much more focused. So you'll find that there will be a difference in the videos, but virtually all the procedures will have videos for them. Now over here on this box, this basically allows you to do a free text search within the entire website of whatever keywords you want. So if we wanted to put in, for example, inguinal hernia, can't spell yet. And do a search on that. It would bring up a series of modules and references which would immediately allow you to click on those if that was what you're interested in and go to that particular subject area. And so the search functions are relatively comprehensive in this, and you can get to material either by using free text search or by using the curriculum categories. So I think that's basically, and you can, if you find material that is particularly interesting to you, you want to save, there's a bookmark section where you can record that for yourself and then pull it back up at some point in the future if there's some reference that you think is useful. So basically that's a broad overview of where we are at the present time. We're interested in having this widely used and basically getting your feedback about the website, telling us what you think is good or bad about it, what other features you would like to see added. As I mentioned, the X-ray images will not appear for about 2 months, and the ABSITE questions probably about the same period of time. Getting it to where it is now has been an enormous amount of effort. There's a huge amount of material in this thing. And so hopefully you'll find that it works reasonably well for you and will be a useful adjunct to what you're doing. The entire package at the present time is free to all residents. The board will be underwriting it. At some point we will need to start charging for it in order to basically meet our costs, or nearly so. We don't yet know just when we're going to do that. It'll probably either be after January or after next July, once we get it into a little fuller form. The intent is to move ahead if it's thought to be useful and to expand it beyond the present broad and common operations to encompass a wider range of things and to put further embellishments on it as people define them that are useful. But we're interested in your feedback primarily in terms of the people who really are the arbiters of whether it's useful or not, are the residents. And we need to know whether you find it useful, and if so, what features you think are the best, what things are non-essential, and what things you might like to see added. So this, as I've said it a couple of times, is really an experiment. It's the board's effort to try and improve education and provide a more standardized framework for it. It's a model that's being looked at by many of the other surgical boards to see if it will be useful or not. The American Board of Thoracic Surgery put up a website about 5 years ago in which they addressed several modules of teaching in thoracic surgery, but that was a much more limited textual references. With that exception, I think none of the other boards have put up anything like this, so this is a new venture, and we have really no idea of how it's going to move forward. There are obviously a huge number of educational things out on the web today, many of which are also available at point of service. Few of them are free. And so we'll be interested in how this goes. So that really summarizes what I had to show you this morning. I hope you'll find it useful, and I certainly think Dr. Obeid would have approved.
Thank you very much.